welcome back. We're moving into our first conversation this morning with representatives of the National AIDS Commission and a representative from the Caribbean Vulnerable Communities Coalition. They are hosting an advocacy and legal training workshop, and they're going to tell us all the details about it and why it's important. I have with me on set Ivan Cruikshank, who is the Manager for Finance and Administration at the Caribbean Vulnerable Communities Coalition, and Enrique Romero, who is the Executive Director for the National AIDS Commission. Good morning and welcome.
Good morning. Nice being here.
Okay, so of course we're starting off the conversation looking at the upcoming training that is taking place. But I wanted to just give us a bit of background, Ivan, on the organization that you work with and what brings you to Belize.
Okay, good. So CVC is a coalition of organizations and individuals. So we have membership from across the length and breadth of the Caribbean who have pulled their energies together to look at issues facing key populations and also addressing the HIV response generally.
Okay.
So we focus a lot around human rights issues, and that's one of the big areas, because when we started in 2004, there was a recognition that there was a gap in the human rights response. We also recognized that human rights was critical, and addressing human rights was critical to an effective HIV response. So organizations, some of them involve government. So for example, in Jamaica, we have some government entities that are part of the coalition, but majority civil society organizations decided that they would come together in a coalition and would respond together. The feeling was that together we can achieve more. So that was our objective when we started out. We do a lot of work across the region in terms of supporting civil society organizations to develop their programs, to better understand the issues, to share best practices, and we do a lot of capacity development and training. So that then leads us to why I'm in Belize. It's one of the initiatives that we are undertaking in a grant that we have through the Global Fund to do capacity development work with civil society organizations around advocacy and legal rights.
And National AIDS Commission is a part of the coalition?
We, as Ivan rightly mentioned, Marlene, Belize is one of the 8 beneficiary countries to CVC COINS grant. And this is in line with our mandate of, the National AIDS Commission is mandated to coordinate, facilitate, and monitor the national response to HIV and AIDS. Part of our mandate also involves advocacy and resource mobilization. So the collaboration that we have with CVC is in line with our mandate, of that advocacy. And in particular, working with our civil society organizations, strengthening them in the areas of stigma and discrimination, policy and legislation, and human rights advocacy as well.
Now, when you talk about advocacy and legal training, who is the target audience that you intend to work with? Are we talking about kind of a training of trainers for the persons who are from the representative organization so they're better equipped to move out? Or the actual population itself?
Well, at the moment, we're focusing on the organization. So what we have done, we have invited organizations to send representatives to the training. The expectation we have is that these representatives would go back to the organization and support the further development of capacity within the organizations. And so that's our objective. It's not technically a train of trainers, but we hope that we can get some amount of training of trainer effect from our intervention.
That it's passed on or disseminated throughout the organization.
And I want to mention that is the same structure that we have in National AIDS Commission. We have civil society representations on the NAC, and it is expected that these leaders would pass on information to the population themselves.
Okay, so let's start off with the area of advocacy, and I want to get the local front first in terms of understanding the challenges that you face in advocating for the rights of persons who are affected in any way by HIV and AIDS.
Right. As you may be aware, that one of the biggest barriers to accessing healthcare services in general, not only HIV and AIDS, has to do with the whole issue of stigma and discrimination. We are implementing a current Global Fund grant whereby we have several activities that are addressing the issue of stigma and discrimination. Recently, the National AIDS Commission launched a video ad, that highlights the reality of the Belizean culture with the risky sexual behavior, the multi-sexual partnerships, and so forth. So that's an area that we definitely, as you mentioned, have challenges, and hence the reason why we are collaborating with CVC. As Ivan rightly mentioned earlier, it's always good to have these our Caribbean partners come in and share their best practices, look at what is working in certain areas of the region, and apply that, adapt that to the Belizean context as well. Because that's an issue in the entire region, I mean globally.
Yeah. And, you know, because it would be great to hear some of the best practices that you'll be able to share. But there is an interesting dynamic, and I want to get your input on it. You know, we speak with representatives of the Cancer Association. We speak with people from the Diabetes Association. And they talk about people who are battling those specific conditions facing stigma and discrimination themselves.
Yes.
People are fearful to have it acknowledged that they are ill in some way or another or seeking treatment. So when I think of a parent who doesn't want to register a child who has diabetes because they don't want anybody to know their child is different,
Exactly.
I can't imagine the additional barriers for a person who suspects or is HIV positive. Do you find the same across the Caribbean, or is that also something that we see widespread in Belize?
Right, and you touch on a very important point in terms of the issue of stigma and discrimination and the examples that you used. So we are addressing the issue of stigma and discrimination in the workplace, in the healthcare settings. But one of the biggest challenges would come with self-stigma. You know, like you said, you are afraid to register a child because the child has diabetes. So how do you actually tackle the issue of self-stigma? You know, I would go to the clinic, and because I have to get a ticket and wait my turn, right away I feel like, you know, the doctor doesn't want to see me because I'm HIV positive. That may not necessarily be the case.
Yeah.
So these are some of the challenges, and again, we want to look at what our Caribbean partners, organizations, you know, are experiencing in the region.
Yeah. So, I mean, the issue around stigma and discrimination, as you rightfully point out, is not just an HIV issue. And, you know, we're just now seeing people coming forward and saying that a relative of mine has cancer. So we know for years people, you know, having cancer was something that people frowned upon and you wouldn't talk about it. So a part of that has to do with the fact that people don't feel that when they get to the healthcare facility, they're going to get a particular type of attention. And that is coming from experience. Some of it, as Enrique said, is around self-stigmatization. You feel that somebody is going to treat you differently because of this particular situation. It's not always the case, but in many cases we know that healthcare workers do not always treat people with these illnesses the same way. And so that is a concern for us, and that is why for us, addressing issues and stigma, particularly in the healthcare facility, is so important to having effective responses, both for HIV as well as for the other diseases that we might talk about. And the experiences in Belize are not unique. They're similar to what happens across the Caribbean, and we are trying to roll out these same type of programs across a number of countries in the Caribbean, because we recognize that the challenges are the same wherever you go. It's a human condition.
So are there any innovative practices that are implemented in any other part of the world that may be able to be adapted for the culture within the Caribbean?
Well, one of the things that we want to look at first of all is that we have developed some training programs with healthcare workers that seems to be doing very well. In Jamaica, for example, there have been a number of programs that have been developed to work with healthcare workers to build their capacity to respond differently to people who are affected by either HIV or they're from key population groups. And so we're seeing quite a bit of success in that particular area, and we would want to be able to support the folks in Belize to do that. We're also looking at issues around understanding the populations, because I think that's a challenge, Enrique. We don't sufficiently understand the populations that are affected.
The vulnerable populations or those who are affected?
The vulnerable populations. We don't understand enough about them. We don't understand enough about the challenges they face. We don't understand about how they access and seek services. And so part of the response has to be to develop that understanding, so that when an individual comes to the healthcare facility, for example, they come in with the healthcare worker being prepared to deal with the challenges. And I use the case of a transgender. The transgender population is one of the most
Understood.
understood population
Exactly.
of all. And they have unique challenges, unique needs, unique ways of wanting to be identified and served. And so building the capacity of healthcare workers to be able to provide that type of service is very, very important. And so we're looking at models as to how we can actually do that. And there are a couple experiences that we have, particularly coming out of Guyana, where they've been extremely successful in terms of their own efforts to reach the transgender population that we would want to share with our colleagues, whether it is in Belize or any other Caribbean island.
Now, it seems to be a dual barrier because when we talk about our HIV statistics in this country, one of the first things, and I know I'm a part of the media, we ask it as well, and you also report it. What are the vulnerable populations? Who are most effective? Who are most at risk? And we know as a fact that some of these vulnerable populations, people who are more at risk of contracting HIV, are persons who are already a part of a stigmatized group. If we're talking about commercial sex workers, for example, there is already stigma with or without implications of HIV. If we talk about men who have sex with men, not homosexuals, but men who have sex with men, that's already, and I hate to use the term, but it fits best, a closeted population in its own. So you add an additional layer of their vulnerabilities or their risks of HIV, and you seem like you have to get through 2 doors before you can be able to access the group.
And that's an excellent point that you mentioned, the closeted, and that's a barrier in itself. Because we know that the population exists, but how do you reach them? They're kind of invisible. Again, in collaboration with CVC, under our current grant, we have a major study coming pretty soon, the population size estimate. The Caribbean Vulnerable Communities, in partnership with the University of Alabama, will be conducting that particular study in Belize. And again, that study should bring to light some of the questions that we have in terms of the population that is most vulnerable.
Now, I would imagine tying in the legal training, the legal rights training that comes from it. Ideally, while you do want an advocate to work on behalf of whatever vulnerable population you're talking, it could be young girls, you also want the individual to be empowered to know and understand their own legal rights. What is the mechanism that you plan to use or will suggest or will discuss, I should say, at the training as to how to get people to learn their legal rights so that they can advocate on their own?
The first thing we're trying to do in terms of addressing that, and you're quite correct, we want to begin with empowering. So the focus of the training, even though we say it's advocacy, a large part of it is about empowering. So it's helping people to understand, first of all, what those rights are and how do they affect me as an individual, and how should I, as an individual, apply the principles that I learned to my own life. So that's the first thing that we want to start out. We recognize that there is not a single place that you have all of these things brought together. And so one of the things that we have developed is that we have developed a manual. And so we have a Caribbean-wide manual, but then we have also then moved to do what we call country-specific manuals, sub-manuals, which brings together all of the specific pieces of legislation and the rights issues that affect each and every population. We look at young people, we look at men who have sex with men, and I like the fact that you said men who have sex with men are not homosexuals. We look at the sex worker, we look at the drug user, we look at a range of populations. And what we have done is that we have packaged the core of rights, and then we have linked those to the local legislative framework. We have linked them to the international legislative framework, and we have said to individuals, you can use this as your starting point for better understanding what those rights are and how you can apply the principles within those rights to the exercise of your daily, going about your business.
Now, what is the outreach, perhaps outside of Belize or within Belize, with the police departments or the people that you would go to report to. You spoke about healthcare workers,
Right.
which I think is important. If I'm advocating for my own legal right, let's say my landlord finds out that I'm HIV positive and wants to evict me, and I have to come in contact with the legal system. It means I have to make a report.
Yes.
It means that somebody on the other hand has to be sensitized to what my legal rights are. Do you also have an inclusive protocol that will...
In terms of Belize, and again, under our current grant, which is linked to, activities are linked to CVC's grant, we had, I think it was late last year, we had trainings utilizing PANCAP's anti-stigma toolkit. And the trainings were held with the officers from the police department, with the officials from the ombudsman's office, with healthcare providers. And again, looking at the same issues that Ivan was referring to in terms of how do you treat a person that comes to make a report. So
Yeah.
it looks at the whole process of making the report and seeing the report follow through, as well as looking at redress mechanisms as well. Under our current grant also, we were able to hire 2 attorneys, part-time, working on a part-time basis, serving as human rights observatories. One is based at UNIBAM's office, the other one is based at the Human Rights Commission's office. So they're also to look at the human rights violations, and it's linked to the shared incidents database in the region. So all of it is linked, no?
Okay.
Yeah, so, I mean, one of the things that we recognize is that it's not just about healthcare workers.
Yeah.
So we're targeting the law enforcement officers,
Yeah.
we're targeting the judiciary,
Yeah.
Right,
because
yes.
we recognize that that's another level at which we need to do some amount of training and sensitization. Because our experience has showed us that oftentimes when people get into the court system, because the judges do not have an understanding of some of the challenges and some of the issues, the decisions oftentimes further fuel stigmatization. And so we're working with police officers, with the judiciary, with other law enforcement agencies, including security guards, to train them to build their capacity to respond. Enrique mentioned what we call the shared incidents database, and that's a online database platform that CVC has developed, and it is operational throughout the entire Caribbean right now, where folks will be able to report to incidents at different points. And we have a pool of lawyers who have been trained as pro bono lawyers through the University Rights Advocacy Project to then review these cases and to support individuals to then move whichever case comes up that they feel is sufficiently robust enough to another level. And to provide guidance to people about some very basic steps that they can take to get some amount of redress. So it's an integrated system that we're actually working on, beginning with the individuals understanding what their rights are, recognizing when those rights are breached, having avenues to redress, reporting first, and then avenues to redress. So I think what we're trying to do is to build out an entire framework for addressing issues of stigma and discrimination.
And that mechanism has been rolled out already?
Yes.
And how has it been,
so-
how much has it been accessed and utilized?
So we have, at the moment, we have two entities from Belize who are actually members of it, and they're now inputting data in it.
Okay.
We have it rolled out in 6 Caribbean countries so far. It was launched in last year, September. It was fully launched last year, September. When we're working with PANCAP to provide the information that comes out of that database to PANCAP, so that PANCAP can use the data to advise and to guide the leadership of CARICOM around some of the initiatives that they might need to take into account.
Okay. Now, gentlemen, I say this so often on the show, people get tired of hearing it. And I'll say collectively as the Caribbean now, recently the reports coming out of the Caribbean is showing that there is an increase in incidence of new HIV infections across the region. We've been doing well, been on the decline, and now once again we're seeing more cases. I find that in general, we don't always like to face situations for what they are. And I say it on the show, let's look ourselves in the mirror, let's address the problems, but we have to identify them first. How will advocacy training and legal rights training of persons who are already infected with HIV change what we're seeing in terms of the rate of new infections?
So,
how will it impact?
So I want to start by saying that we have recognized, and all the evidence so far has shown us, that treatment is an effective prevention strategy. So if people are able to get into treatment, get into care, and to have a significantly reduced viral infection, that means that the possibility of transmission is reduced in a significant way. So our efforts right now are aimed at getting people into the system to make sure that they're going on treatment and they're staying on treatment and they're getting to viral suppression. And that we believe that if that strategy is applied, then we should see a decline in new infections arising from just applying some very, very effective treatment strategies. So advocacy is aimed at addressing that. It seems like a roundabout way of addressing the prevention thing.
Well, we've tried many mechanisms. We've talked about using condoms. We've talked about being monogamous. We've talked about getting tested. And now you're talking about the mechanism that you're talking about is getting persons who are already infected to suppress the viral load so that they don't pass it on or be aware of how they may pass it on.
And as Ivan rightly mentioned, Belize is no exception to the characteristics. What we have done at the National AIDS Commission, for example, we have a problem with men getting tested. So in the past 3, 4, 5 years, what we have done is we have taken the testing to the business establishments that are mostly male dominated in an effort to get more men to get tested. And as Ivan rightly mentioned again, in Belize, our adherence rates are very low. Less than 50% of the people that have been diagnosed are on ART. That in itself is an issue. Because if we are able to get people to adhere to their medication and change their lifestyle in general, we can reach levels of very low viral load. And again, that can aid in the
Is it adherence that is the predominant issue in Belize, or getting on medication in the first place?
Well, if you look at the treatment cascade, it starts with testing, knowing your status, the treatment, and then the viral load suppression. So we have issues from the very first pillar, which is getting people tested to know their status.
Now, it seems that when we talk about HIV, obviously, this is one of the most common ways that it's transmitted is through sexual intercourse. And you know, it's interesting because people perhaps love talking about sex within their own environment. And then when it comes into our public domain, we behave a bit prudish, like we shouldn't be having this conversation over coffee. But there are behaviors that put us at risk. And when we talk about, for example, and I want to get into the MSM population, because I know people hear me say not the homosexual but the MSM. I've been exposed enough to these organizations to understand that they're persons who engage in risky behaviors but have a normal lifestyle outside. And this increases the vulnerability. Can we talk about that and what can be done to perhaps reduce the stigma, but also educate the individuals who are engaging in these behaviors as to how they're exposing themselves to risk?
So a couple of things. One is we have found in a number of cases that the double life is heavily a function of a stigmatizing environment. So people have these dual lives, and so we recently did some studies and some work across both the Dominican Republic and in Jamaica, looking at what we call the down low phenomenon.
Down low.
Right. These are what we call the men who don't identify as MSM. And it was interesting because the guys pretty much, they say, look, I cannot allow other people to think of me as somebody who is involved in this type of behavior. So I have my girlfriend, and then I can't,
or my wife,
exactly. And I cannot, or both, and I cannot do anything that would let them think that I'm having sex with a man. So what I do is I go out, and the opportunity sometimes when it presents itself is not one where it is a controlled environment. I don't have condoms, I don't have all sorts of stuff. And we have had to be saying to people, look, if we begin to reduce the stigma that is associated with sex with a male, then he may feel more comfortable to say, okay, let's have a conversation about what we're going to do. Let's ensure that if we're doing it in a protective way. And so we believe that this conversation is a very important conversation that needs to happen. The same thing happens with a woman who is a sex worker. A lot of women who are sex workers, they get up and they leave their houses and they go out in the evenings and they go to do sex work, and nobody at home, nobody in the family, nobody in the community knows that they're doing sex work.
Yeah.
In fact, they migrate to another country oftentimes, do sex work, and you hear somebody will say, well, she's gone abroad to work. And so some of the support mechanisms that you would have to help you to be more responsible and to be more protective are not present because you're by yourself in a space. And so we feel that having this type of conversation and opening up the conversation to normalizing it a little bit more will help people to take much more precaution and to reduce the risk that they take.
Now, it's also been shown that when you're talking about transactional sex, when you're talking about money for any kind of sexual favor, that there's also additional risks involved. Because if I am providing a service, then I have less input over what type of protection can be used. And I want to introduce that because I have been, we have conversations with so many people on this show, and I've been exposed to the concept, which they say is something that is becoming more common in Belize. There's commercial sex work, but there's also what they call gay for pay, which is young boys offering sexual services. They don't identify, once again, as homosexuals, but they will offer services for money. How does the transaction, the money transaction, increase the vulnerabilities?
There was a study that was done down south a few years ago by a consultant, and the study was showing that, for example, in the Banana Belt area where you have a lot of migrants working there, the study showed that there were some women who were engaging in transactional sex for what, $5, $10, so that they could feed their children. And as you pose the question, how does that increase the risk? You are vulnerable, you're engaging in transactional sex, so you have little leverage to say, well, you know what, to tell the partner, the person, you need to use a condom or not, because you find yourself in a position of need. So the person can dictate, whether he or she wants to use a condom or so forth. The same thing with the study was showing that young boys, for a cell phone, for high-end tennis, were engaging in sex with older men. And again, the risk is higher because you're in a position that you cannot negotiate.
Right. And I think that's the data across the Caribbean is consistent on that. In the incidents of where transactional sex is occurring, the power to negotiate the use of condom is significantly reduced. And one of the things that we have recognized is needed is greater efforts at helping people to build resilience, to build that capacity to say, look, yes, I can choose to engage in transactional sex, but not with you. So your money doesn't mean that much to me that I risk my life. And that is a capacity that is very limited, and we have to be working on. And as we do our prevention work, a lot of our work has to be around building that resilience among young people in particular, among most vulnerable women, to say to men, look, yes, we might be in need, but we're not in need to the point we are going to engage in risky behavior. And I think that's part of what we need to do a lot more of.
If you look at the commercial sex workers population in Belize, the incidence is pretty low. It's 0.8, 0.9% because of as Ivan mentioned, they have the power to negotiate.
I mean, in Jamaica, one of the things that we have seen the incidence among sex workers move from 12% to 2.5% or 2.4%.
Because they become empowered.
Because they are empowered. And they have no problem at all walking with a condom. So when a man shows up for sex and he doesn't have a condom, they said, I have mine.
Exactly. Right?
And so they feel empowered, and it's about building that same level of empowerment among all of the populations and the groups to say, look, yes, I'm prepared to have sex with you, but I walk with my condom. I'm confident to walk into a shop and get a condom, and walk with it. To go into the NAC and to get a condom and to walk with it if I'm going to engage in some sort of transactional sex.
So it does show that there has been some success in the messaging and advocacy that has taken place. Let me ask you, as persons who are deeply involved in the advocacy of HIV prevention, now looking at our statistics and seeing that, yes, there are new infections being reported, more so than we have seen in the recent past. What do you think needs to be a part of our new message to the public? As I mentioned, it's strange to me because I feel like I've been hearing ABC for as far back as I can remember. And maybe not as much now as I used to when the Caribbean was in an extremely difficult predicament. But what is the new message, you think? Understanding our societies today, understanding stigma and discrimination, understanding changes in laws that we're seeing. What do we need to say to the public?
But here's the thing, and it's interesting that you raised that. We have just been trying to do a review in Jamaica about our own approach. One of the things that we have recognized is that the message of fair is no longer resonating. And so for years, we use the message of fair to say to people, you know, this is what is going to happen, etc. We're now moving to say, love yourself. If you love yourself enough, you're going to take precaution. If you love your family, you want to spend more time with them. You want to engage a little bit more with them. And so using this message of loving yourself, we find is likely to give us the better outcomes than the message of fair. So shifting from fair messaging, which we know for years was the message that we use, to a message that tells people, you know, if you love yourself sufficiently, you're going to prevent STIs. If you love yourself, you're going to prevent something happening to your kids. If you love yourself, you're going to prevent engaging in unsafe sex. So that's the time you're going to go get tested. You're going to know your status. You know, so that is where we need to go. That is a new messaging. That's a new direction that we need to take our prevention messaging.
Right, and recently with the launch of the Mix5 study, the data again was showing that the comprehensive knowledge of Belizeans in terms of HIV and AIDS is very low as well. You know, so we have to
in prevention.
Yes, overall HIV and AIDS.
Wow.
The facts of HIV and AIDS, the myths of HIV and AIDS. You know, there are some people that still believe that by shaking an infected person's hands, they can get HIV and AIDS. So that also we have to work on in that aspect as well.
Okay. All right. So you have your advocacy, and we shifted off a bit, but I think it's all very important.
Yes.
It's increasing your awareness. But you have your advocacy and legal rights training taking place today. What happens after you have concluded your sessions in terms of follow-up and perhaps an action plan that is engaged after this?
Okay. So one of the things that we want to do at the end of today is that, first of all, we're inviting the organizations to not only come to hear what we have to say, because I think it's more about having people come in and sharing their own experience in advocacy. And so we believe that there's a whole body of advocacy work going on in Belize that people can learn from and organizations can learn from each other. And so we've asked a number of the organizations to bring to the table their own advocacy strategies so that your counterparts can hear how you're doing it, and what we can do is support you in doing it better. The second thing that we want to do at the end of the day is to come away with a national advocacy plan. So we're looking at about 3 different priority issues around treatment, around comprehensive prevention, and around human rights. And we're saying if we can develop some messaging that we can take out of the trainings today and match it with the legal literacy over the next 2 days, we can have an action plan. When we're also asking people to identify a couple groups or individuals that you want to target over the next year with your messaging, and what resources you will need, and let us see how we can support you in getting to these individuals, getting your messages out, and getting you some of the resources that will allow you to be able to scale up your own work. So we're going to have an action plan coming out of it. Then in September, there's going to be a regional advocacy training, or well, not a training, but a meeting where we bring together participants from the different countries to look at and say, okay, you did this at the national level, let us look at how we scale this up to the regional level, so that we can engage with the PANCAP leadership, we can engage with parliamentarians across the region, and to ensure that the issues that you have raised as important advocacy issues are taken to another level. And PANCAP and ourselves are supporting that initiative. So that's the direction that we want to go for the next, as a next step.
All right. Well, it sounds like you guys have an interesting day ahead. We wish you the best of luck with your training today, and definitely hope to see the fruits of your labor in reduction in new infections, but of course in a more empowered population as well.
Brilliant.
All right, we're going to go ahead and take a break. When we come back, we're going to be talking about family planning with BFLA, so stay tuned.